Thank you, Kyle Sang, for inviting me to talk here this afternoon. So I'll be going over the endoscopic management of colorectal dysplasia in patients with inflammatory bowel disease. This is a pretty large topic, and I have 10 minutes to go over it, so I'll be brief. Okay, so in this talk, I'm going to briefly go over the incidence of colorectal cancer in patients with IBD. I'll go over the risk factors for dysplasia and cancer, and then I'll discuss the new guidelines for colorectal cancer surveillance in patients with IBD with the focus on terminology change to describe these lesions, how we detect dysplasia using chromoendoscopy, and then the management of dysplasia. So as we all know, colorectal cancer is increased in patients with inflammatory bowel disease. If you look at previous meta-analysis using older data, the cumulative risk of colon cancer and ulcerative colitis is about 18% at 30 years. However, updated meta-analysis looking at 9 population-based studies have shown that the standardized incidence ratio of colon cancer in ulcerative colitis and Crohn's colitis is 1.7 times that of the average risk patient. So overall, the cumulative risk of cancer is 5% after 20 years. And the reason for this is effective surveillance guidelines and also preventative medications that Dr. Wong had talked about, mainly anti-TNF therapy. So the risk factors for dysplasia in patients with IBD are longer duration of disease, greater extent of colonic involvement, increased inflammation, younger age of disease onset, backwash ileitis, family history of colon cancer, primary sclerosing cholangitis, which actually increase the risk about 4 times the average IBD patient, and inflammatory polyps. So older guidelines from 2010 recommended that patients with ulcerative colitis and Crohn's colitis, if it involves at least 1/3 of the colon, begin surveillance for colon cancer after 8 to 10 years of disease. And during the colonoscopy, we would take random biopsies every 10 centimeters and at least 33 biopsies throughout the colon. And we would repeat this every 1 to 2 years. However, these guidelines are based on older literature and older technology, mainly non-high definition colonoscopes. Therefore, the CNIC guidelines are the newer set of guidelines for the management of these colorectal cancer and IBD, and these came out in 2015. So the first thing that the CNIC guidelines addressed is they tried to standardize the nomenclature and how we describe these lesions in order to better, for all of us to communicate with our colleagues. What they suggested is that we stop using terminology like DOM lesions, which is dysplasia-associated lesion or mass, stop using adenoma-like lesions or non-adenoma-like lesions. These are very confusing, and it's very difficult to communicate with our colleagues when we do use these terms.